Once again, I left my room without wearing my skirt because I have a black slip-on, so in my mind, I think in my room I thought I had my clothes on, and I get on the elevator, and of course there's men there, and it wasn't until we got to the first floor that I'm like, oh. So then I had to wait for the elevator again, go back up, so I'm sorry I'm late. Anyway, I just want to warn you before we get started, I'm very nervous about speaking in front of people. My mouth gets very dry. My lips will be sticking on top of my gums like this. My heart races, my GI tract races. And then I have to race out of here, but I'll always come back, all right? So you just network among yourselves, and I'll always come back. Just remind me to take off the microphone because it's wireless, because I wouldn't want to share that experience with you. All right, so CCRN review. Who's taking the test? Many of you are, right? Right? Don't worry, don't worry. I'm going to give you all the information you need in order to pass. After this course, you shouldn't have to go home and read that big, thick core curriculum, that boring book. You have that? Just pay attention here. Everything out of my mouth's in your handout, so you don't have to take any notes whatsoever. Just sit back and just listen. So let's talk about the CC... What? You didn't get a handout when you came in? Yeah, that's the handout. Yeah, there's pearls in there. There's pieces of information you need to know in order to answer test questions. Okay, so here's what we're going to do today, since today is day one. We're going to do endocrine, 3%, neurological is 7% on the exam, GI is 6%, renal is 5%, hematological is 3%. So this is what we're going to do today. Tomorrow, a piece of cake, cardiac, pulmonary, piece of cake. You don't even have to bring your brain tomorrow, but I'm glad you have it today. And also on the exam, you'll notice that 20% is comprised of professional caring and ethical practice. I really don't cover any of this. I do not cover any of this. I know it's worth 20%, but I don't cover it. Caring practices. Get a life. Collaboration. I don't get along with physicians. Response to diversity. Systems thinking. Critical inquiry. What does all this mean? Facilitator of learning. I don't go into that. They say that the test is focused on the synergy model. And the synergy model encourages nurses to view patients in a holistic manner rather than the body system's medical model. So then I say to myself, then why is the test set up according to body systems? Endocrine, GI, renal. The synergy model creates a comprehensive look at the patient. It puts the patient at the center of nursing practice, like the patient never was, with the realization that each patient and family is unique, with varying capacity for health and vulnerability to illness. The CCRN exam do not test for knowledge of the synergy model, so you don't have to worry. I get a million phone calls. People say, oh, your book doesn't have the synergy model. Well, the CCRN exam does not test the synergy model or its terminology. It is just a theoretical model within which the test has been designed. So what does all this mean? It means that someone in the AACN office got a master's degree in nursing. This is what it means. See, once you get a master's degree, or when you're going for your master's degree, they use all different kinds of words. I went to NYU back in the 80s, so a long time ago. And the words there were paradigm. Paradigm. For 4 years I went there. I'm like, what the heck's a paradigm? You know, and the man's dynamic helix of spiraling motion and blah, blah, blah. So anyway, you don't have to know that. You do have to know that it's a very difficult test. It's very, very difficult. Very difficult. Smart people fail it, and stupid people tend to pass it. Now, you might see that this is true. I work with people. They have CCRN after their name. Some people I work with have CCRN and CEN. And then some people I work with, I think they make up initials. They got CNNP, they got BC, stuff over here. And I say to myself, I won't want these people to touch me with a 10-foot pole. You know, and then some very nice people I work with, some very great nurses, have failed it. You go figure it out. I think because if you don't do mental aerobics, you get very tired. you know, the test, you get fatigued. You're up to question 160, you get tired. You're tired. So that's why you have to do a lot of mental aerobics before the exam. Make sure you wear red or yellow, right? Make sure you wear red or yellow, because red or yellow, those colors increase mental alertness. It increases the electrical firing from one synapse to another, and it's very important to have your synapses firing when you're taking the test. Also, you want to eat salt. Salt also increases mental alertness. Those of you that work the night shift know that at 4 or 5 o'clock in the morning you go into machines, and what are you buying? Chips, pretzels, salty stuff. So you got to eat a lot of salt. You know, eat a pound of peanuts, a pound of bacon. Who cares if you die of congestive heart failure? You'll go down with your CCRM. Another thing is you need to have a bad attitude when you take the test. Make sure you're cranky, irritable, PMSing, whatever. If you're menopause, you know, that's PMS every day, so make sure you're really cranky. Whenever you're irritable, cranky, angry, you tend to retrieve information much quicker than when you're intimidated. A long time ago, I used to be intimidated by nursing administration. Not anymore. But like 29 years ago, I used to be very nervous, you know. And they'd come up to me and they'd say, "Miss Kasparis, are those underwear lines showing through your uniform?" You know, they'd be addressing some very vital issues in nursing practice. And I'd be standing there 29 years ago going, "Oh, please give me a good evaluation, please." Then I'd be driving home at 8 o'clock in the morning, and I'd be saying to myself, you know, what the heck was she looking at my butt for anyway? And I'd be thinking of all the things I should have said to her. See, so whenever you're angry, you're able to retrieve information much quicker. I mean, I know when I'm fighting with my husband, I can think of things that happened 15 years ago, and in great detail. So make sure when you take the exam, when you take the test, make sure you're cranky and you're irritable. Matter of fact, I always get told at work I have a bad attitude. So if you work, and at work you're always told that you have a bad attitude, you're in like Flint. You'll pass this test. Right? My supervisor's like, Miss Kasparis, every weekend's the same thing. Every weekend I have to write you up for your attitude. You know, because sometimes I have difficulty dealing with some physicians, not all of them, but some of them. Some that try to kill patients, and I just have like problems with that. And I'll call her up and I'm like, "Can you come down to the ER, please? Dr. So-and-so's trying to knock off a few more patients." It's like, your attitude, it's your attitude. So every weekend I get written up. So she keeps on saying to me, every weekend, "When's it going to stop? When's it going to stop?" I'm like, "Brenda, birds only peck at the good fruit. That's why you write me up every week." Make sure you do, mental aerobics, right? You got to do mental aerobics. You must do at least 150 test questions 5 days before the exam. And the reason why you have to do that is you got to do mental aerobics so you don't get tired. So the first day you'll sit down, 5 days before the test, you'll sit down, do 150 test questions. It'll take you 2 hours. And after you do 20 questions, you're going to want to go to the refrigerator, but you can't. You're going to want to pick up the phone, but you can't. You got to sit there and do 150 test questions, and it'll take you 2 hours. The next day, it'll take you 1 hour and 45 minutes. The next day, 1 hour and a half. The next day, 1 hour and 15 minutes. Then, right before the exam, one night before the exam, you do 150 test questions. It'll take you like 45 minutes. So then when you go take the test, it's a piece of cake. You do 150 questions, and you're like, bring on the exam. So make sure you do mental aerobics. And you could do the same questions over and over. In your handout, you have questions. Just do same questions over and over 5 days before the exam so you don't get mentally fatigued. You do got to remember on the test that there are 25 questions you will not be able to answer. I don't care who you are. All right? 25 questions you will never be able to answer. Even if you memorize those questions, go to a library and look up the answer, you won't be able to find what the answer is. For example, they got some guy coming in with a GI bleed. Blood pressure is 60 palp. And it's 60 palp for 4 days. I'm saying to myself, what kind of hospital is this guy in? But anyway, he comes in with a GI bleed. He's been in the hospital 4 days. His BP's been 60 palp for 4 days. They were doing leather-fed lavages. I don't know. Anyway, they say to you, why is he confused? Some saying, no blood getting to his brain. This is what I'm saying. But when you look at the answer choices, it's not there. A said, because he's on lever-fed lavages, it vasoconstricts your blood vessels, and that's why. B said he's on Tagamet. Whenever you give people Tagamet and they're hypotensive, you get confused. C says, we got a lot of blood transfusions as well. C says he's going into DIC. And then D says he has ICU psychosis. So, what's the answer? I don't know. Any of them could be the right answer, right? So there are 25 questions you won't have the answer to. Another guy comes into the hospital, and he's a COPD. You got him on a 40% oxygen mask. So then they say he's drowsy and unresponsive. What's the problem? I'm thinking maybe 40% is a little too much for a COPD, I'm thinking. Not in the answer choices. So, there are 25 questions you won't be able to answer. So I don't want you to get nervous when you're taking the test, because a lot of them appear on the first and the second page, or your screen's on the computer. So you're like, wow, I can't answer that. Oh my God, I can't answer that. And so now you're all nervous. You're like, oh my God, thank God I didn't tell people I was taking this test. Thank heavens, no one knows I'm taking it. All right, you won't have a clue, but don't worry, all right? Don't worry, you'll get everything else correct. Let us start with endocrine. Endocrine is 3%. 3%, right? Don't worry, it's in your handout. SIADH, diabetes insipidus, DKA HINC, and hypoglycemia. This is what you have to know. If it's 3%, you're going to see 6 little itty-bitty baby questions. I'm going to give you enough information to answer all 6 questions absolutely correct. You will not have a problem with endocrine whatsoever. Do not go home and read that core curriculum and everything else. Pay attention here. You're going to get all 6 questions absolutely correct. Let's talk about syndrome of inappropriate ADH and diabetes insipidus. Here we go. Syndrome of inappropriate ADH, which is SIADH. What does it mean? It means you got too much ADH. Now you know, or maybe you don't, you know that ADH is made in your hypothalamus and stored in your posterior pituitary, right? And ADH, when it goes down to your kidneys, makes your kidneys hold on to water. So ADH makes your kidneys hold on to. So anytime you see the word ADH, the initials or letters ADH, you have to say to yourself, water. ADH, water. ADH, water. ADH, water. So ADH makes you hold on to water. ADH goes down to your kidneys and makes your kidneys hold on to water. ADH goes down to your distal, convoluted, and collecting tubule. Don't worry, we'll be doing that again in renal. ADH goes down to your distal, convoluted, and collecting tubule. Just think of the impact of nursing care that's going to have on your patients. So ADH goes down to your distal, convoluted, and collecting tubules, thereby causing your kidney to hold on to water. Good. Now, whenever you're going to hold on to water, you're going to decrease your sodium level. Right? You're going to hold on to water, you're decreasing your sodium level. You get what's called a dilutional hyponatremia. Matter of fact, whenever you're taking the test and you see the words dilutional hyponatremia, you got to say SIADH. I say dilutional hyponatremia, you say SIADH. Whenever you see the words dilutional hyponatremia, you say SIADH. Good. On the exam, they have a lot of stories, right? Stories and then questions. Just read the question first. Most of the time, you don't have to read the story. You don't. Listen to me. So you get a decreased sodium level. You get a dilutional hyponatremia because you're holding on to water. You're also going to get a decreased osmolarity. You know, the way you figure out people's osmolarities or body concentrations is by 2 times in their sodium level. So let's say my sodium level is 140. What's my concentration? 280. I'm normal, because the normal concentration of your body is 275 to 295. So that if I have a sodium level, let's say a 120, what's my concentration? 240. I'm hypoosmolar. I have a sodium level of 160. What's my concentration? 320. Concentrated. So when people are holding on to water, it decreases their sodium level. They become hypoosmolar. Their osmolarity is less than 275. And they also have a decreased urinary output, because you know that ADH goes down to your kidneys, making your kidneys hold on to water. And if my kidneys are holding on to water, I don't have too much in the Foley bag. That's easy. Here we go. Let me just go through some causes. Causes of SIADH. Oat cell carcinoma, tumor in the apical portion of your lung, makes ADH, which goes down to your kidneys, making your kidneys hold on to water. Also, viral pneumonia. Viral pneumonia. They're not too sure why. They think with viral pneumonia you have some hypoxic areas in your lungs, which then causes your posterior pituitary to release ADH, which goes down to your kidneys, making your kidneys hold on to water. Head problems. A head problem, not like a mental thing, but a structural head problem, can give you SIADH. SIADH. So that the causes of SIADH are oat cell carcinoma, viral pneumonia, and a head problem. Causes of SIADH, oat cell carcinoma, viral pneumonia, and a head problem. And that's when you're taking the test, you can look at your friend, and if question 4 is about which of the following patients would be at risk or SIADH, and you do like that. It looks like a Catholic gesture, right? Like a Catholic kind of a gesture. So that the cause of SIADH are oat cell carcinoma, viral pneumonia, head problem. Should you wake up one day and have oat cell carcinoma, viral pneumonia, or a head problem, you're going to release all this ADH, which goes down to your kidneys, making your kidneys hold on to water. Good. You're going to get them all right. You got 6 questions on endocrine. Increased osmolarity, anesthesia, and analgesia and stress also would make you have a little bit of SIADH. This is not really that important to know, but although anesthesia, you know, if you work in recovery room, you know that's true. In recovery room, people get a lot of fluids in the OR, and yet in the recovery room, they're just not putting out any urine, right? They're not putting out any urine. Everyone thinks, well, let's put a Foley in, let's do this, let's do that. But many times anesthesia and the pain medications would cause you to release more ADH, which then cause your kidneys to hold on to water, and you don't have a big urinary output. Syndrome of inappropriate ADH means you have too much ADH. If you have too much ADH, you have a decreased sodium level, decreased serum osmolarity, decreased urinary output. Notice that this arrow is going up. Therefore, these arrows go down. This is true no matter what you do, no matter what the topic is. If one arrow goes up, the other ones always go down. That's the way it is. For example, if my pH goes up, I'm alkalotic. What happens to my intracranial pressure? Goes down. What happens to my potassium level? Goes down. I'll tell you when we do liver disease, I'll tell you that people with liver disease should never have a, should never have an increased protein, right? They shouldn't get increase in acids. So people with liver disease should never have a low potassium level, because it makes their kidneys hold on to potassium. Whenever you hold on to potassium, you hold on to an ammonium ion, which is not good when you have liver disease. So I'll tell you the things that people should not have when they have liver disease would be a low potassium level, increased protein, right? Increased acids. So the point I'm making here, if one arrow goes up, the other go down. If this arrow went down, these would have to go up. So what we have to do is just figure out one lousy arrow, and the answer's in the bag. Whenever I say dilutional hyponatremia, you say SIADH. All right, good. And what are the causes of SIADH? Good. And whenever you have SIADH, you have too much ADH, therefore you're holding on to water. Good. Now, a complication would be seizure activity. When people have SIADH, you got to watch it for seizure activity. And the reason why they get seizure activity is because, maybe I'll draw it over here, if you have SIADH, you get a dilutional hyponatremia. And, so let's say Mary Jones is 70 years old, and she comes into your hospital, and she comes in with viral pneumonia. Really, she comes in with sepsis, dehydration, because that's what most old people come in with, and then she gets viral pneumonia. Anyway, initially when she comes in, she's like a little dehydrated. We'll make it 300 in the serum and 300 in the cell. She's a little dehydrated. And then, because of the viral pneumonia, she tends to hold on to lots of water. In holding on to water, she dilutes her sodium level down to 120. If she has a sodium level 120, it gives her an osmolarity or a concentration of 240. So now if she's 240 in the serum and 300 in the cell, water always goes to an area of higher concentration. So that a dilutional hyponatremia makes the water go into the cell. So whenever you have a dilutional hyponatremia, water shifts into your cell, into your brain cell. Then she'll be hanging her legs over the bed, in the bed, over the bed, in the bed, over the bed, in the bed. Then she'll be playing with her IV. Then you have to tie her up. Then when enough water goes into her brain, she becomes unconscious, like the rest of the old people in the hospital. But still keep it tied, because you wouldn't want her to hurt herself. Then when enough water goes into her brain, she'll have seizure activity. So a complication of SIADH is seizure activity. All right, good. How do you treat people with SIADH? Well, you should get rid of the oat cell carcinoma, the viral pneumonia, or the head problem. In the meantime, fluid restriction. Fluid restriction, because the SIADH makes you hold on to water. And then a hypertonic solution, such as 3% sodium chloride, can be given, but only like at 25 cc's an hour. 3% sodium chloride has a concentration or an osmolarity of 1,500. 1,500. So if you put something with a concentration of 1,500, it's going to pull water out of the cell. It's going to stop your seizures, but it'll put you into failure. But that's all right. We'll give you a Lasix or whatever. So 3% sodium chloride, remember, only like 25 cc's an hour, and only for like 3 or 4 hours. And then you gotta keep an eye on the patient, because that's what doctors tell you to do. Keep an eye on her. You're like, hey, thanks a lot. I've been wandering aimlessly throughout the unit, not knowing my purpose. And you got to remember, no hypotonic solutions can be given to the patient with SIADH. Hypotonic solutions would be 2.5 dextrose, 0.33 saline. What else? D5W. Even though you learned D5W is isotonic, it's only isotonic in the bag. Once you give D5W, your body eats up some of the glucose and changes the osmolarity by about 30 or 40 points. So it's 295 in the bag, normal osmolarity. Once you give D5W, it drops down to like 240, which is now a hypotonic solution. So that if I have somebody who comes in with diabetes insipidus, SIADH, they're shifting water into their cell. And then if I was to give, let's say, 0.33 saline, or how about 0.45 saline? 0.45 saline, that's another hypotonic solution. That has a concentration of 155. I'm adding something very dilute to that woman, and when I add something very dilute to her, I dilute it down maybe to 200, and then bada boom, all the water goes into the cell. So hypotonic solutions cause water to go into the cell, and you don't want that when people have SIADH, because they already have water going into their cell. So no hypotonic solutions. And here's just a little schematic of what happens. If you have an osmolarity of 295 and 295, both in your serum and in your cell, you're normal. Hypotonic solutions would be 0.45 saline, 0.33 saline, 2.5 dextrose. Let's say I'm giving 0.45 saline, has a concentration of 155. How would you know that? Look on the IV bag, the fifth line will tell you. And if I'm adding something very dilute to her, I wind up diluting this 295, dilute it down to 260. Now, if I'm 260 over here, 295 over here, water shifts into the cell. So whenever you give a hypotonic solution, where's it going? In the cell. D5W, 275 in the bag. After you infuse it, your body eats up some of the glucose, changes it down to like 245. Again, it's hypotonic solution once you give it. If anything, you want to give a hypertonic solution, such as 3% sodium chloride, D5 normal saline, or D5.5 normal saline. That's what you would do for people with SIADH. Because if I'm going to give a hypertonic solution, I'm going to force water out of the cell into the serum. By taking it out of the cell, your seizure will go away. Although I do have to keep an eye on you for fluid overload and congestive heart failure. So that was easy now. We just did SIADH. The key point there is SIADH, the causes are oat cell carcinoma, viral pneumonia, head problem. Should you have SIADH, whereby you either have oat cell carcinoma, viral pneumonia, or head problem, you're putting out too much water. Well, you put out lots of ADH, which goes down to your kidney, making your kidney hold on to water. You get a dilutional hyponatremia. I got to watch it for seizure activity, and I got to stay away from hypotonic solutions. Good. The opposite of SIADH would be diabetes insipidus. Diabetes insipidus. It's the opposite. SIADH, you had too much ADH. So this one, you hardly have no ADH. If you don't have any ADH, you're not going to be reabsorbing water at your kidney site. You're going to be losing all your water. You can't see through this outfit, can you? No? My goodness. So anyway, you don't have any ADH. Therefore, you're not holding on to any water. You're losing all your water. You're losing a lot of water. Lose anywhere from 6 to 24 liters in a day. You're urinating up a storm. What happens is, if you're putting out all this urine, you have an increase in your sodium level, because you're not holding on to any water. If your sodium levels increase, what's your osmolarity? Increase. You'll become hyperosmolar. And then you have an increased urinary output, again, anywhere from 6 to 24 liters a day. Putting out a lot of urine. And it's very, very clear. A lot of people don't believe it's urine. They think someone's putting water in the urinal or water in the Foley bag or whatever, but it is urine. So people with diabetes insipidus, big urinary output. Causes of diabetes insipidus, head problems. Notice that head problems is the first one, whereas head problems was number 3 on SIADH. So if you're going to have a head problems, chances are you're going to go into diabetes insipidus. And Dilantin. Dilantin can give you diabetes insipidus. So when I read this, I said to myself, I'll never remember this. Then I said to myself, yes, I will. Diabetes insipidus is DI. Dilantin is DI. So then I said, maybe I'll remember that. No. So really the cause of diabetes insipidus are head problems and Dilantin. All right, good. Whereas the cause of SIADH is oat cell carcinoma, viral pneumonia, and head problem. So diabetes insipidus, you don't have any ADH. Don't have any ADH, low levels of ADH, you have an increase in your sodium level, because you're putting out all that water, increase in serum osmolarity, and a big increase in urinary osmolarity or urinary output. The osmolarity is 1.001 to 1.005. Very, very dilute urine. Very, very dilute. 1.001 to 1.005 is a specific gravity. Dilute urine. It looks like water. And, of course, the complication would be severe hypovolemia. Because if you're putting out 20 liters on Monday, you're going to become hypovolemic. And you're going to go into shock. So a complication of diabetes insipidus would be shock. Very good. This is easy. You know, I had a young kid come in, head trauma, a 16-year-old kid comes in, head trauma, has diabetes insipidus, putting out unbelievable amounts of urine. And the physician shows up and tells me to give him D5W. I'm like, I don't think so. Not today. Maybe tomorrow, but not today. So I tried to explain to him why I thought it was the wrong thing. And of course, you always get told, where did we go to medical school? You know, they always say that to you. I'm like, I didn't have to, okay? Then I called up the supervisor. Anyway, big to do. He wants me to give this kid, who has a sodium level 174, he wants me to give him D5W. Now, his rationale is that sodium level is 174, you don't want to give him anything with salt in it. And my rationale is if he has a sodium level of 174, he's very intravascularly depleted because he's putting out 20 liters a day. So my concern is intravascular volume, hemodynamic stability. And so normal saline is what you would give this young man until, you stop the diabetes insipidus. Whereas if I was to follow the order of D5W, where would that fluid go? In his cell. So how is that going to help his heart rate, which was, very tacky and everything else? Treatment is you have to give ADH. So diabetes insipidus is pretty easy if you have to, fix it up. If you have diabetes insipidus and you have no ADH, I give you ADH. And it comes all different ways, right? It comes all different ways. You can give ADH, IV, you can give it IM, you can give it sub-Q, it has a nasal spray. It comes all different ways, ADH, all different ways. Matter of fact, they should make some kind of spray, ADH spray. Because whenever you go on trips with your kids, they always have to pee. So then you get in the car and you take the ADH and you spray it in the car. They breathe it, it gets absorbed, it causes them to hold on to water, and then they don't have to pee the whole trip. But anyway, you're going to give fluids to increase intravascular volume, and that's why I was against the D5W. And you're going to monitor urine-specific gravity. Again, the specific gravity when people have diabetes insipidus is 1.001 to 1.005. Good. And you got to monitor EKG for ischemia. Whenever you give ADH, also known as pitressin or vasopressin, it's not only a water hormone, but it also is a vasoconstrictor. So you got to keep your eye on the cardiac monitor for any kinds of ST depressions, because that would mean ischemia. So it's easy. I tell you, it makes you want to go take the test, the endocrine part, doesn't it? All right, so just to review, diabetes insipidus, the two causes would be head problem and dilantin. And what would be the big to-do when you have diabetes insipidus? I know you're putting out 20 liters, but I got to watch you for shot. Good. And how am I going to cure the diabetes insipidus or take care of it while you have it? I'm going to give you ADH. And whenever I give you ADH, you got to keep my eye on the cardiac monitor. All right, good. I have a sodium level of 120. Who am I? Diabetes insipidus or SIADH? SIADH, good. I'm seizing and I can't get up. Who am I? SIADH. I got a serum osmolarity of 320. Diabetes insipidus. Good work. Here we go. Hypoglycemia. Always a question or two on hypoglycemia. Whenever people are hypoglycemic, you have to know the signs and symptoms. Initially, you get cardiovascular signs, and then you get central nervous system signs. The cardiovascular signs would be tachycardia, palpitations, diaphoresis, irritable, restlessness. Then you're going to get some CNS signs, which would be confusion, lethargy, slurred speech, seizure, coma, and then you're dead. Now, rather than writing these down, you wrote these down in nursing school. You didn't remember them then. What would make you think you're going to remember them now? Give it up. All you got to do is remember why you get these signs and symptoms. Whenever you're low in glucose, your adrenal medulla knows this. And whenever you're low in glucose, your adrenal medulla will release adrenaline. And adrenaline goes to your liver and makes your liver convert glycogen into glucose to get you out of the predicament. So whenever you're low in glucose, what's released? Adrenaline. And adrenaline goes to your liver and makes your liver convert glycogen into glucose to get you out of the predicament. So whenever you're low in glucose, adrenaline is released. That's why whenever you're low in glucose, you're anxious, you're irritable, a little tachycardic, a little, clammy, whatever. Why? Because of the adrenaline release. And then, of course, if you didn't release enough adrenaline, maybe you're on a beta-adrenergic blocker. Maybe you're on Inderal, Corgard, Tenormin, Lopressa. If you're on a beta blocker, there won't be that adrenaline release. Therefore, you won't be putting out any glucose. Well, your liver won't be converting glycogen into glucose. So then you'll be low in sugar, and then your brain cells will die. You'll get confusion, lethargy, and slurred speech. Guys in the Broca area kick the bucket. Seizure come, and then you're dead. This is why you need a nurse to save your life. Or let's say you did put out enough adrenaline. Let's say you did. And when the adrenaline went to your liver to convert glycogen into glucose, you had no glycogen to be converted into glucose. Why? Because you were drinking all weekend. And whenever you're out drinking, your liver is so busy converting the alcohol that it really doesn't have time to store any glycogen. So what happens is you then go hypoglycemic. So whenever you are hypoglycemic, the initial signs are that of adrenaline release. And then, if you get any CNS signs, it's because your brain cells are dying. Which is a good thing in my hospital, you get promoted. They promote you right away. Right to the top. It's only my hospital, I'm sure yours is different. Matter of fact, in my hospital, if you come for a job, let's say you have no personality, right? None whatsoever. People hate you as soon as they meet you. Your face is all contorted in misery and grief. You never laughed in your entire life. No one has ever touched your body in your entire life. You have no social skills. You have no friends. You have no life. You're downright miserable. Boom! Right to the top! You make it in my hospital. Heaven forbid they promote a happy, perky person, you know? No, I'm sure yours is different. Here we go. Thing you got to remember is, if you're on a beta-adrenergic blocker, if you're on Corgard, Tenormin, Inderal, Lopressa, if you're on a beta-adrenergic blocker, which blocks the release of adrenaline, you don't get any of these signs. You don't get any tachycardia, palpitations, diaphoresis, irritable, restlessness. You don't get those signs when you're on a beta blocker. The only thing you're going to get, see, there's no adrenaline release. The only thing you're going to get when you're hypoglycemic is confusion, lethargy, and slurred speech. Now, this happens all the time to old people. All old people are on beta blockers. I dare you to find me an old person that's not on a beta blocker. All right? I have to have a little candy. I'm having a little hypoglycemic reaction myself. So anyway, you're in a nursing home. And Mary Jones is 70 years old. And she's on a beta blocker because all old people are, because it prevents sudden cardiac death. Heaven forbid you're 94 years old and you drop dead and die, okay? Won't make any money on you. So that's why you come into the hospital and we give you a prolonged death, okay? So now Mary Jones is 94 years old, whatever. Anyway, she's on a beta blocker. And on Monday she gets the flu. She don't eat. Tuesday she has the flu. She don't eat. Wednesday she has the flu. She don't eat. She hasn't eaten for 3 days. Wednesday afternoon she goes hypoglycemic. She don't show you any tachycardia, palpitations, diaphoresis because she's on a beta blocker and there is no adrenaline release. The only thing she shows people in a nursing home is confusion, lethargy, and slurred speech. And what do you think everyone's thinking is happening to her? Stroke! She must be having a stroke. Next thing you know, you bring her in, CAT scan, MRI, do this, do that, do that, do that, tie her up. Give a little D5W. All right, but anyway, so that's the scoop there. So just when you think people are stroking, they may just be low in sugar. Okay, good. So the signs of hypoglycemia are that of cardiovascular signs and symptoms, and then you have CNS signs and symptoms. The initial cardiovascular signs and symptoms are due to adrenaline release. Good. Let's say a few words about DKA and HINK. DKA and HINK. DKA, diabetic ketoacidosis, and HINK is hyperglycemic, hyperosmolar, non-ketotic coma. Or hyperosmolar, hyperglycemic, non-ketotic coma. Whatever, HINK. Some people call it HOC, H-O-C, hyperosmolar coma. But most people call it hyperglycemic, hyperosmolar, non-ketotic coma. Okay, first let me just cover who gets HINK. Who comes into the hospital with HINK? Old people. Whenever you're old, you're going to get HINK. Because whenever you're old, your pancreas gets tired and you don't put out the right amount of insulin, so then your blood sugar goes up. So old people get HINK. Also, a diet-controlled diabetic gets HINK. A diet-controlled diabetic gets HINK. Whereas an insulin-dependent diabetic, someone on insulin, would get DKA. Other people that get HINK, people on TPN. On the exam, have a woman that's 20 years old, and she has Crohn's disease, and she comes in with TPN, and then she winds up having HINK. Whenever you're on TPN, you're getting anywhere from 50, 60, 70, 80% glucose. After a while, TPN will make your pancreas tired and you don't put out the right amount of insulin, so your blood sugar goes up. And then people with pancreatitis will get HINK. We'll be covering pancreatitis in great detail when we do GI, but pancreatitis is a condition where your pancreas eats itself, which is a very scary thought to think, that you have an organ in your body that one day decides to eat itself, you know? And you're like, hey, stop that. Why are you doing that? Cut that out now. Hey, you're the only one I have. Stop that. And so pancreatitis is the autodigestion of the pancreas by itself. Your pancreas eats itself. And if your pancreas is busy eating itself, it won't have time to put out the right amount of insulin, so your blood sugar goes up. So who are the people that get HINK? The people that get HINK would be, right, look, old age, right, old age. Diet-controlled diabetics, people with TPN, and people with pancreatitis. So the people that get HINK would be old age, right, old age, people who have diet-controlled diabetes, total parental nutrition, and people with pancreatitis. Also, for your own information, people on steroids can get HINK, and thiazides also. This is only for your own information. Thiazides and steroids can also give you HINK. Thiazides, they believe that thiazides cause your kidneys to hold on to glucose. And steroids, they're not sure, but they think steroids make your body resistant to your own insulin. So what are the causes of HINK? Old age, diet-controlled diabetes, people on TPN, and people with pancreatitis. Good, good, good. And the cause of SIADH would be osteocarcinoma, viral pneumonia, head problem. Should I have SIADH? I have too much ADH, so I hold on to lots of water. I get a dilutional hyponatremia. Matter of fact, whenever you see the words dilutional hyponatremia, you say SIADH. Good. I got to be aware of what complication? Seizure activity. Good. Hey, what are the causes of diabetes insipidus? Head problems and dilantin. And what would be a complication of diabetes insipidus? Shock. I have a sodium level 176. Who am I? Diabetes insipidus. Good. I got a sodium level 105. SIADH. Good. DKA and HINK. Let me compare one with the other. All right, comparing DKA with HINK. People with DKA have a blood sugar of 400 to 900. It could be higher, but it usually isn't. It usually ranges between 400 and 900. These people are dehydrated. They are anywhere from 4 to 6 liters behind in fluid. And people with HINK have a blood sugar of 1,000 to 2,000. They have a really high blood sugar, people with HINK. And because their blood sugar is so high, they are severely dehydrated, anywhere from 6 to 8 liters behind in fluid. So you see that people with HINC are far more hyperglycemic than people with DKA. And that's because you can hang out with HINC for a long time. And because you hang out with HINC for a long time, that's why your blood sugar can be 1 or 2,000. Matter of fact, many times when you draw blood on people with HINC and you get a blood sugar that's high, people don't even believe you. I had an elderly woman and I drew her blood, and her blood came back 1,500. Matter of fact, I said to the intern, hey, your blood sugar is 1,500. He's like, hey, what do you expect when you draw the blood from the arm with the D5W? I'm like, shut up. I said, I drew the blood, and then I saw the IV. The woman's got HINC. So then he says to me, God bless you. He thought I sneezed. I'm like, you know what? Don't go throwing around any blessings, okay? Because if anyone needs a blessing, it's the lady on the stretcher. You know why? You're her intern, okay? So anyway, people with HINC have a very, very high blood sugar. So people with DKA now have no insulin. They don't have any insulin, right? They have no insulin. Where people with HINC have insulin. So when I read this, I said to myself, this must be some kind of typo. Because how can you tell me that these people with no insulin only have a blood sugar of 400 to 900, whereas someone with insulin has a blood sugar of 2,000? Then I thought maybe this was like confused or something. Like I would think someone with no insulin would have a blood sugar of, 2,000, and someone with insulin would have a blood sugar within 400 to 900. That's what I was thinking. But then I learned why people with DKA only have a blood sugar that goes to about 900. And the reason why is these people go into a coma. After about 5 days, you go into a coma. And when you go into a coma, usually, you're at home, and usually people at home would notice this. And because they notice this, they bring you into the hospital, and that's why your blood sugar only goes to like 900. People with HINC hang out with HINC for weeks and weeks and weeks and weeks and weeks. And because you hang out with HINC for so long, that's why your blood sugar can go to 2,000. Because you can hang out with HINC for weeks and months. And that's why your blood sugar gets so high. Where people with DKA will go into a coma after a week, and because they're in the coma, you usually would bring that family member into the hospital. It depends, I guess, who it was. Somebody you don't like, you might want to keep him in the kitchen chair and tie him so he doesn't hurt himself. If you have kids, a good place to bring your kids is to a nursing home. And the reason why you want to do that is kids have a lot of energy. And there are just some days that they have like too much energy and you don't know what to do with them. Bring them to a nursing home. And a lot of people in nursing home walk around in HINC. That's the point I'm going to make here. Kids have a lot of energy. Old people have no energy. So when you take your kids to go visit the old people in the nursing home, you'll notice that the old people will suck the energy out of your kids. Because whenever you put someone with no energy next to someone with energy, there's always an energy exchange. You probably even notice that at work. Don't you go into work and like I'm afloat? So let's say I go down to let's say I go up to SICU, right? And I'm checking the assignment, I'm seeing who I'm working with, I'm like, not that I don't like those people, they're very nice people, it's just they suck my energy. As soon as you go into the unit, they're like, you're like, hey. And then let's say I get floated down to the ER, I'll check the assignment, I'm like, because those are energy-giving people. I tell you, when I'm working, if I have 3 energy-sucking nurses and 3 energy-sucking patients, I can't even make it home. 8 o'clock, 8:30 in the morning, I go to the parking lot because I'm going to go home. Because I work the night shift. I don't blend in with day people, I hate the day shift. No, not so much the people, but just, the people. I'm sorry. Sorry. I'm strictly a night person. Do we have any night people here? Oh, thank God. All right, good. Too many higher-ups on the day shift. And all of our day people are aspiring to be leadership positions, you know? So anyway, I'm strictly a night person. All right, but anyway, so at 8:30 in the morning, let's say I'm working with 3 NG-sucking nurses. I have 3 NG-sucking patients. So I go to my car at 8:30, and I have to drive home. And I don't have that long of a ride, but, you know, there's a chance I could fall asleep. So I say to myself, let me just close my eyes for 2 minutes. So I close my eye in the car. The next thing I know, someone's like this. They're knocking on my car window. It's noon. The day babes are going out. Oh, because they can't eat in the cafeteria. They go to the diner. So the day babes are knocking on my car. I'm like, oh, what day? And then I'm saying, what day is it? Am I coming? Coming to work? No, I already went to work. Coming to work? So, anyway, there's always an energy exchange, okay? Always there's energy givers and energy suckers. So kids have a lot of energy. Old people have no energy. So you take your kids, you bring them down to the local nursing home, and you have the old people suck the energy out of them. That's what I do. I give my kids, I give them a baggie, I put hand cream, a comb. We go to Claire's in the mall, we buy little clips and everything, and I tell them, I say, we're going to go to the nursing home, we're going to fix up everybody's grandma and grandpa, okay? They're all going to be on TV tomorrow. The next day we'll watch TV. Any old person they see on TV, they're like, oh, I fixed her up. I'm like, oh, you did a good job. Anyway, so I bring them to the nursing home. So every nursing home has visiting hours from 11 to 4 or whatever. So we go there, and all the people are in what's called the activity room. Yet there's no activity going on. All right, but they have them in a wheelchair, all these old people, and they're like dead in an upright position, okay? So then I take the kids, and I throw them on the old people, and I tell the kids, you know, take the cream, rub, rub, rub. I say, if you rub good, their wrinkles go away. Rub, rub, rub. So they're rubbing the old people, they're rubbing, then they're combing the hair. They ain't making them look good or anything. They're putting like a clip over here, whatever. But the old people like that. You know, don't you like when kids are combing your hair and everything? I would love that. So, but what's really happening is the old people are sucking the energy. They're sucking the energy out of the kids. So then when you leave at 4 o'clock, I'm like, okay, say goodbye to everyone's grandma, grandpa. Go ahead, go say. And how cute are 4 or 5-year-olds, right? They say just like it is. They're like, I'm not kissing her. Her mouth smells. I'm like, kiss her, I'll tell you. And then you take the kids and you put them in the car. I don't even got them all strapped in. I don't even have them all strapped in, and half of them are like that. Right? The old people suck the energy out of them. So very important. But anyway, I'm in the nursing home with the kids, and this little old lady comes to me. She says, can you walk me to my room? I want to get my photo album to show the children. I'm like, no problem. And she says to me, hold on to me really tight, though. My vision is very blurry. I'm like, oh, great. Lousy day off you have from work. I'm going to be doing mouth-to-mouth on a 90-year-old, you know? Like I got... All right. But anyway, so I was holding on to Grandma, and we're walking into her room there. And as I'm walking into her room, my sneakers are sticking on the floor. They're sticking. And I'm like, Mary, what'd you drop, maple syrup? She's like, no, I passed my water, which is an Italian way of saying I peed. Right? Little Italian ladies always say make water or pass water. So anyway, if she urinated on the floor and my sneakers are sticking to it, sounds like sugar in the deal. So then I got the one and only nurse in the whole nursing home to do a finger stick on this woman, and she's running around with a blood sugar of 800. I guess that's why her vision was very blurry. So you can hang out with Hank for a very, very long time, and that's why your blood sugar gets so high. These people are very dehydrated because of the osmotic diuresis, and their dehydration causes cerebral dehydration. Matter of fact, people with Hank have a 95% mortality rate. And not that you should ever die from Hank, but the reason why you die is because of misdiagnosis. When you come in with Hank, because you're so dehydrated, your brain's all dehydrated. And because your brain's all dehydrated, you present with neurological symptomatology. You come in with one-sided weakness, focal seizures. Everyone thinks you're a neurological event. And then by the time the neuro doctor shows up, you're dead. Because they never show up when they're supposed to show up. Does yours show up right away? No, they show up a day later. Okay, people with DKA are in a state of acidosis, right? People with DKA are in a state of acidosis. And the reason why they're in a state of acidosis is because They need to break down fats for energy. And whenever you break down fats, you release ketones, which puts you into a state of acidosis. And because the patient is in a state of acidosis, the patient will be doing Kussmaul breathing, an increase in rate and depth in order to blow off the CO2. People with HINC, on the other hand, have no acidosis, none whatsoever. And the reason why they don't have any acidosis is because these people have insulin. And the circulating insulin they have prevents the breakdown of fats. So there is no ketosis. And because there is no ketosis, there is no acidosis. So one big difference between DKA and HINC, besides these people being very, very dehydrated, would be people with HINC have no acidosis. No acidosis, where people with DKA have acidosis. People with DKA do Kussmaul breathing, increase in rate and depth of breathing, where people with HINC breathe LTBB. Right, it's called LTBB. And what is LTBB? Well, it stands for lucky to be breathing. That's what it stands for. And why are these people lucky to be breathing? Because their brains all dried up. Right? People with HINC are very, very dehydrated. Could also stand for little tiny baby breaths. Either or. Lucky to be breathing, or little tiny baby breaths. So now, why should you be taking little tiny baby breaths, or why should you be lucky to be breathing? It's because your brain's all dried up, that's why. So this kind of breathing they do. Now, it's not an approved abbreviation, so you wouldn't put LTBB in any of your notes. Although I did, because there's a nurse I work with, and I know you're supposed to like everybody, but anyway, I don't like her, okay? All right. First of all, she got a name plaque that's about this big. She got to go slide with through doors. She got every initial. She got, just added a few more. She added BLS, and then a little C, ACLS, and a little C, because she's certified in CPR and ACLS. Anyway, it's about this big. Which is okay. But anyway, everybody's stupid. We're all a bunch of morons. She's like the smartest thing in the world, okay? So we're all morons, and she's like really smart. Okay. And so she's always copying my notes. Right? If you're so smart, think of your own wording. So anyway, one day I put LTB in my nurse's notes. Figure that. There, I put LTBB. So I put the LTBB, and I come back the following weekend, and do you know? She copied the same thing. Right? Well, what's going on here? Is this, oh, man. Stephanie, could I have my markers? These aren't coming off. And a wet rag. Hate when that happens. Okay. Hello. I got this on video. Hello. Anyway, so... And I need if this don't come off with water, we have to... Nail polish remover. Nail polish, thank you, darling. Nail polish remover. But anyway, so I write in my notes, LTBB, and then a week later, I noticed that she wrote in her notes, LTBB, and so then I went up to her, I'm like, Sue, do you know what LTBB stands for? And so she knows everything, right? So she's like, why, of course. I'm like, oh, because, you know, I'm old, my brain's not working. I figure what it stands for. So, you know, she's like looking around trying to remember what it stands for. Really, she doesn't know because she copied from me. Okay. So then she says to me, well, you had it in your notes. I said, yeah, I did, but I forgot. Oh, I remember what it stands for. It stands for lucky to be breathing or little tiny baby breaths. She was like, really? Really? I'm like, yep, I made it up, and that's what it stands for. So anyway, in the chart it has LTBB. So what she did is she went and she put a line through it. She took the chart and her notes, she put a line through it. She wrote the word error, and then she put her initials and the date. All right. See, you wouldn't know it's an error. You wouldn't know it's an error because there's a line through. You have to write the word error. And then she put her name on it and everything. Okay, good, this is working. And then she started walking away, and I'm like, Sue, you know, you also gotta, what a mess. You also have to put your, what did I tell her? Social Security number. She was like, really? I said, yes, you need your Social Security number. Because, you know, Sue, anybody, you know what, I need fly ones, yeah. I said, you know, because anybody can put a line through anything and write the word error and put anyone's initials. So you really got to, you know, put your Social Security number. I'm like, it's new legislation. Didn't you read? Thanks a lot. And I said it was an AJN. It was an AJN. Didn't you read it? She was like, oh, yes, I did. Oh, yes. All right, so then she puts her Social Security number, and then she writes that down. All right, good. I'm going to keep this all here in case, I'm going to trade you. Thank you, Jerome. Thank you. All right, so then she wrote her Social Security number, right? Blah, 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 blah. Then she put the chart away. I'm like, Sue, so you got all those things, right? You got all those things, Social Security number, the date, you got to put your license number. She was like, what? I'm like, you need your license number. Sue, you're changing a legal part of a document. I mean, Sue, it was in, it's new legislation. I mean, didn't you read it? She was like, oh, yes. Let me tell you how to treat people with DKA. You give insulin. Right? You give insulin. Matter of fact, people with DKA, you put them on an insulin drip. And you also got to give them fluids. Got to give them fluids. But more so, insulin. People with HINK are going to need fluids. And then you give insulin. You see, when you're taking care of people with DKA, the key here is insulin. Right? Someone comes in with DKA, even though their blood sugar is maybe only 600 or 700, you'd be giving them insulin IV push. You'd be giving, 60, 70, 80 units IV push. Then you'd be putting them on insulin drips. Whereas people with HINK, that woman that came in with a blood sugar of 1,500, I only had to give her 20 units. 20 units of regular insulin, like this. Then I waited like an hour and a half or whatever. Then I gave her another 20 units. And then after that, I just had to show her an insulin bottle, like this. That's all I had to do. Because they already got insulin. They definitely need fluids. Now, what kind of fluids you going to give these people? Well, both people, you got to start off with normal saline. Because normal saline is isotonic and it stays in the intravascular compartment, so you're always going to give them normal saline. Then, once you got a nice blood pressure, good urinary output, the pulse is decent, then you're going to switch over to 0.45 saline. Because where does that solution go? In the cell. And that's good because they're dehydrated. And then after their blood sugar comes down to like 250 or 300, then you want to hang a bag or two at D5.5. Reason why you want a D5.5 is two reasons. Reason number one, you would hate for someone who is so very hyperglycemic when they come in to now become hypoglycemic because of the insulin you gave. So by hanging D5.5 has dextrose in it, you make sure that don't happen. And then whenever you're hanging 0.45 saline, which goes into the cell, you always wind up putting too much fluid in the cell. And so by giving D5.5, you'll take whatever fluid went in the cell that you don't need it there, it'll take it back out. So it'll decrease cellular edema. So the IV solutions you give would be normal saline, which is isotonic. Then you give 0.45 saline, which is hypotonic. And then you give D5.5, which is hypertonic. This is easy. Tell you, it makes you want to go into work, doesn't it? No, not yet, eh? All right, we'll get you there. We'll get you there. Got to remember one thing. When people come in with DKA, you must see a normal potassium level. When people come in with DKA, they must have a normal or high potassium level. If you have someone with DKA who has a low potassium level, they're gonna die. So you definitely have to have, definitely a normal potassium level, although you really want it to be high. When people come in with DKA, you really want them to have a very high potassium level. Let me explain this to you. Potassium and your pH works pretty much in a reciprocal way. For every change in your pH by 0.1, your potassium level will change by 0.6. So that potassium, you know, primarily lives in your cell, right? You have a cellular potassium level of 150, whereas in your serum, potassium is only like 4.5. So you see that most of your potassium is in your cell. Now, potassium is positively charged. All right. When you go into a state of acidosis, you have extra hydrogens, which are positively charged. So therefore, your body says, you know what? I got extra acids. I got to get rid of the acidosis. Yes, you will hyperventilate, cause more breathing to get rid of some of that acid. But on a cellular level, the way you get rid of the acidosis is you hide the hydrogen. What will happen is hydrogen will hide into the cell. It'll get out of the serum and go hide in the cell. Now, if your hydrogen is hiding in the cell, the positively charged ion is going in the cell. That's Mr. Potassium's house. He's positively charged. So you got all this positively charged stuff in the cell. So then you got to even it out. So potassium says, if you guys are coming in here, I'm going out. So whenever you are in a state of acidosis, acid shifts into the cell, and potassium will come out of the cell. So that's why in a state of acidosis, you should have a high potassium level, a high serum potassium level. And you don't have to know this equation, but for every change in your pH, your potassium should change by, every change in your pH by 0.1, your potassium should change by 0.6. And the reason being is, in a state of acidosis, potassium will come out of the cell, and hydrogen will go into the cell. There's a shift between potassium and hydrogen ions. Someone comes into the hospital and they have a pH of 7.45. And they have a potassium level of 4.5. So they're normal. All of a sudden, they get a drop in their pH. They drop their pH by 0.1, 7.35. Therefore, the potassium level goes up by 0.6. I have a pH of 7.25. My potassium level is going to be what? 5.7. I have a pH of 7.15. My potassium level is going to be 6.3. And with a pH of 7.05, I expect my potassium level to be 6.9. So whenever someone comes in with a state of acidosis, you expect to see a high potassium level. Well, let me explain this to you. If, well, let me do this. We had a patient come into the ER, and we had all new GNs working, and they did like 1 week. They were in orientation for a week, and then all of a sudden the hospital needed them to work as nurses, you know? So, sad. So anyway, they got these 4 GNs working in the ER. You know, people say to me, why are you so anti-nurse administration? I'm like, heck. You know, I go down to the ER, and I'm working with 4 GNs. Right, 4 GNs. I don't have a problem with new people working in the ER. I don't believe you have to work on a med-surg unit for a year, get a bunch of bad habits, and get burnt out, and then they send you down to the ER. You know, I believe you could be a new nurse and start in a critical care environment. You just shouldn't count as staff while you're learning. So, I mean, if you were to say to me, where would you put, 4 nurses, GNs, who can't read monitors? They haven't their monitoring course yet. So they can't read a cardiac monitor. They can't start an IV. They can't draw blood, and they can't push meds. I mean, where would you put them? I mean, I'd put them in housekeeping for a little while. You know what I'm saying? But no, not my hospital. My hospital's like, you know what? Put them in the emergency room. Kill people as soon as they come into the hospital. So anyway, we're working with 4 GNs, blah, blah, blah. Okay. This young guy comes in, a police officer, 34 years old. Comes in pretty much in a coma. His blood work, he had a pH of 7.0, I think 5, but I think it's 07. But anyway, we'll make it 7.05. And his blood sugar was 660. He has no history of diabetes whatsoever, 34-year-old cop. No history of diabetes, and blood sugar was 660. And his potassium level, I believe, was 4.0. And his CO2 was, 4 or 6 or whatever. So he's in a bad state of acidosis. Okay. On autopsy, they found that he had a cyst, a benign tumor, a benign pancreatic tumor, which caused him to go into DKA. All right. And because he never had diabetes, I mean, he was at home and he was drinking a lot of fluids and putting out a lot of urine and drinking fluids and putting out urine, so that's where he lost all his potassium, all the urination he was doing. So when he came in, what happened is the ER doctor says to the new GNs, they draw blood, and the blood work came back, and the nurse, when I talked to the GN, she said, well, I was telling him what all the results were, and he told me to shut up and just tell him what's abnormal. She was reading like the whole panel, you know, it was like 20 results. She was just reading the whole panel, and he just told her to shut up and just tell me what's abnormal. So she didn't tell him about the potassium because 4.0 is a normal value, and she told him everything else. So he said add 2 amps of bicarb to the IV bag because they can't give anything push yet, so they did. And by adding bicarb to the IV bag, you're giving him bicarb. So now his pH is going to come up to 7.15, right? But now if you're going up, the potassium is going to be going down because now the potassium is going to go back into the cell. So now we have a potassium of 3.4, right? Then they continue to give bicarb, and now it's 7.25, and then this goes to what? 2.8. Then the bicarb continues, let's say 7, because I think 2 amps is like a lot, because once you control the blood, once you give them insulin, the pH will pretty much correct on its own. But anyway, 7.35, and this goes to 1. Bear with math. Oh, 2.2, very good. 2.2, good. All right, so now his potassium level is 2.2, but then they gave him insulin for the blood sugar, which drops your potassium level by 1 point. So now his potassium level is 1.2, and now he goes into VFib. He goes into VFib, and he succumbs to the VFib. So, you know, like who made the error here? I mean, of course, the physician made the error, without a doubt, but I really believe nursing administration must be held accountable for these staffing kinds of issues. But anyway, maybe not my life. So the thing is whenever people come in with a state of acidosis, you always want them to have a high potassium level. And that the most common cause of death in DKA, believe it or not, is from hypokalemia. That's the most common cause of death. So anyway, we did a lot of the endocrine. We did all of it. And we're going to see how smart we are when we come back from break, because we're going to have questions, and you're going to see that you're going to get them all right. Okay, back to work. Now watch how smart you are. What is the effect of ADH on urine formation? What is the effect of ADH on urine formation? And you would say C, retention of water and concentration of urine, because ADH goes down to your kidneys, your distal convoluted and collecting tubule, thereby making your kidneys hold on to water and concentrating your urine. The releasing stimulus for ADH is normally, what would normally make you release ADH so that you hold on to water? What would it be? Yes, increased serum osmolarity. Should you become dehydrated and have an increase in your serum osmolarity, that would cause you to release ADH to go down to your kidneys to make you hold on to water. Good. The normal range of the serum osmolarity, what's the normal range? And you would say the normal range is 275 to 295. That's the normal range for your osmolarity, right? 275 to 295. If you have anyone with a concentration greater than 295, they are dehydrated. Whereas any osmolarity or concentration less than 275, they would be pretty dilute or fluid overloaded. The syndrome of inappropriate ADH is manifested clinically as And you would say water intoxication state. So SIADH is manifested clinically as water intoxication state because in SIADH you hold on to lots and lots of water and you get a dilutional hyponatremia. In addition to its effect on body water equilibrium, ADH is also a vasopressor, right? It's a vasopressor. That's why when you have people with diabetes insipidus and you give them ADH or pratressin or vasopressin, you always got to keep your eye on the cardiac monitor and observe for ST depressions, which would mean ischemia. The symptomatology you would assess in the patient with SIADH results from don't afraid to use the same answer. Don't afraid. Water intoxication. Right. So the signs and symptoms you see in a patient with SIADH are all due to water intoxication. Good. The cardinal sign of inappropriate ADH secretion, or the sign of SIADH, the cardinal sign of SIADH would always be A, dilutional hyponatremia. Matter of fact, whenever you see the words on the exam, dilutional hyponatremia, you say SIADH. And what are the causes of SIADH? And you would say ocell carcinoma, viral pneumonia, head problem. Which of the following laboratory findings would be present in a patient who has SIADH? What would you find? What would they have? This is SIADH. This is where they're holding on to water. A low serum sodium. Holding on to lots of water dilutes your sodium level. They are very hypoosmolar and have hyponatremia. Matter of fact, they get what's called a dilutional hyponatremia. The patient with SIADH may present with seizures. Good. So people with SIADH, a complication would be seizure activity. Whereas if I have diabetes insipidus, putting out 20 liters a day, my complication would be shock. As a staff nurse at ICU, you're assigned to a patient recently admitted with diabetes insipidus. Which of the following patients would be likely to develop diabetes insipidus? Who here would get diabetes insipidus? Head trauma. Because what are the causes of diabetes insipidus? Head trauma and Dilantin. So, someone receiving thiazides, a young woman with severe pneumonia, someone on lots of pratressin, they're all going to get SIADH. So the answer here is a head trauma patient. Someone with skull fracture, always got to look for that guy getting a case of diabetes insipidus, because the two main causes of diabetes insipidus are head trauma and Dilantin. Even though in your core curriculum it breaks it down that the causes of diabetes insipidus is central causes and nephrogenic causes, you don't have to go into that kind of detail, not with 6 little itty-bitty baby questions on endocrine. You just got to know that people with diabetes insipidus either have head trauma or too much Dilantin. During your assessment, which of the following findings would be present in a patient with diabetes insipidus? What is it that you would probably see? Yes. People with diabetes insipidus are going to have a very high serum sodium. And that's because they don't have any ADH. If you don't have any ADH and hold on to any water at your kidneys, you're urinating out everything, 20 liters a day, your sodium level is going to go up. Your specific gravity would be 1.001 to 1.005. You're going to have a very big urinary output, and your urine osmolarity is going to be greater than 295. Because you're going to be very dehydrated. The nurse understands a major complication of diabetes insipidus would be what? Hypovolemic shock is a complication of diabetes insipidus, whereas seizures is a complication of SIADH. Good. Tell you, it makes you want to go take the test, doesn't it? No, not yet, eh? Well, we'll get to that. Evaluate. Do you get extra money for your CCRN? Some people do. What do you get? Quarter? 50 cents? What do you get extra? How much extra? $1 an hour? $3 an hour. Ooh, that's very good. Whoa. Nurse recruiters, listen to this. $3 more. I think that's pretty decent. Oh, where is it? What hospital? St. Michael's. I was going to say St. Michael. Where the heck's St. Michael's? Newark. St. Michael's in Newark. Go there. Well, what's your base salary, though? Is it like $15? Are you unionized? Bingo. That's it. That's the key word. Are you unionized? They are. I'm pro-union. For those people in administration that don't like me, let me give you a real reason not to like me, okay? I'm very pro-union. All right, here we go. It's the only way you're going to fix up the work environment. You know, there's a horrible... Well, they say there's a shortage. There's really not a shortage. There's still 2.8 million registered nurses. There's just a shortage of nurses wanting to work in a hospital setting. Yeah. Because I've been a nurse for a very long time in the working conditions, and it depends where you work. But in all the hospitals I worked in, and I worked in a lot, it's been fairly undesirable working conditions. And I wasn't ever looking for a lot of money. I'm just looking for an opportunity to give safe patient care. But you put me in a unit now, and now you're giving me, it used to be 2 patients. Then went to 3. Now, because there's a night shift and, like, apparently all patients sleep, sometimes I get 4. I don't know about you. I skits out with 4. Even 3 I'm skitzing. You give me 3 vents with 5 pumps each, I'm a little skitsy right there. I know I got to put somebody in autopilot for a few hours. You know, and then when you call the nursing office, they're like, well, do the best you can. Do the best you can. I'm like, well, you're a nurse. Why don't you roll up your sleeves and help me over here? Do the best you can. And then you know, if you're not unionized, they can really fire you for any reason. You know, so I mean, to come up to me and like, how would we like a challenge tonight? I'm like, challenge tonight? I'm in my 50s. What kind of challenge do you think I need at this point in my life? I haven't seen. It's a challenge for me to be able to get dressed and get up in the morning. What do you anyway? How would you like to go neonatal ICU? I'm like, what drug are you on, neonatal ICU? I've been an adult critical care nurse for 29 years. You're going to put me in neonatal ICU? Go away, will you? You know, make everything a big to-do. You know, it's the same thing up there. It's the same thing. It's just things are smaller. Things are smaller. You got different ventilators. The ventilators are about the size of this thing over here, right? That's their ventilator. Yeah, I mean, like vital signs. What's your blood pressure supposed to be when you're born 3 months too early? I don't even know. I don't even know how to take a blood pressure. I don't even think you're supposed to use their arm. Use the umbilical cord? I don't even know what you use. I don't know how to take a blood pressure. I don't know nothing. She wants me to go up there for a challenge. I'm like, what's this going to be? The challenge of killing little babies? What are you, out of your mind? Get out of here. Are you refusing? Are you refusing? Yeah, I'm refusing. And if you pull some crap that you're going to fire me, I'll make sure on the way out of here, I'll slip on the wet spot on the floor. I'll own the place, all right? Get out of here. Evaluation of laboratory findings in a patient with diabetes insipidus would show. What would you see when someone has diabetes insipidus? Right, specific gravity, 1.001 to 1.005. Because, see, in diabetes insipidus, you have an increase in your serum osmolarity, an increase in your serum sodium. The most dangerous complication of diabetes insipidus is hypovolemia. Oh, really shocked. Good. Diabetes insipidus is characterized by all but which of the following? If someone has diabetes insipidus, yes, they're definitely going to get a low blood pressure, big urinary output, tachycardia. They will not have that specific gravity, right? The specific gravity that they will have is 1.001 to 1.005. Which of the following is characteristic of diabetes insipidus? Would people with diabetes insipidus have a low urine osmolality or osmolarity, meaning their urine is very dilute? Yes. Would they have a serum osmolarity that's increased? Yes. Would they have a high serum sodium level? Yes, so the answer is all the above. Good. 68-year-old woman's admitted with a blood sugar of 1,200. She's severely dehydrated. Respiratory rate is 18 a minute and shallow. What would you first suspect? So she's 68 years old. She got that old age. Yes. Hyperosmolar coma. It can't be DKA because it's 18 minutes, right? 18 breaths per minute. So, and look how high the blood sugar is. So it has to be hyperosmolar coma, also known as hyperosmolar hyperglycemic non-ketotic coma. Good. It's important for the nurse to identify those patients at risk for developing HINC. Which condition would not predispose a patient to develop HINC? Which would not give you HINC? CVA would not give you HINC. Whereas TPN therapy can give you HINC. Pancreatitis can give you HINC. Old age can give you HINC. And people on thiazides or steroid therapy can also go into HINC. Non-ketotic hyperosmolar coma, or HINC, is not usually associated with. Yes, A. It is not associated with anything with ADH. It is associated with diabetes at recent onset, mild or diet-controlled diabetics. It's also connected with old age, use of diuretics, steroids, hypertonic solutions such as TPN. The nurse understands that the primary cause of the classical manifestations of HINC is a result of what? The signs and symptoms you see of HINC. Is it intravascular dehydration or is it dehydration, cellular dehydration? It's cellular dehydration, so the answer is markedly elevated serum glucose. Because to have a glucose level of 1,000 or 2,000, you are very dehydrated, both in the serum and a lot in the cell. And the cellular dehydration, the cerebral dehydration, gives you one-sided weakness, makes the patient aphasic, gives him seizures, twitching. He looks like a neurological event, and that's why it's often misdiagnosed HINC. So the markedly elevated serum glucose level is what gives you all the signs and symptoms in HINC. An altered mental status in a patient with HINC results from intracerebral dehydration. Good. Which of the following findings would not be present in someone with HINC? Would they have severe dehydration and absence of ketosis? Yes. Would they have a high osmolarity? Yes. Would someone with HINC have a glucose level above 650 and often greater than 1,000? Yes. So the answer is A. They would not. People in HINC would not have a Kussmaul respirations because they're not in a state of acidosis. Evaluation of a patient's laboratory values with HINC would include what? If someone has HINC, will they have a bicarb level of 12? No, because they're not in the state of acidosis. Would they have a urinary sodium of 60? No. When we do renal, you'll see that they should have a urinary sodium less than 20. The answer is a serum osmolarity of 340, because people with HINC are very dehydrated, and dehydration is reflected in an osmolarity greater than 295. Further assessment of diagnostic data in a patient with HINC would reflect what? Would people with HINC have a state of acidosis? No. Would they have ketones? No. Would they have a low hematocrit, meaning they were diluted with water? No. Azotemia. That's what they would have. People with HINC have azotemia. It's a temporary increase in your BUN and creatinine due to dehydration. That's what azotemia is a temporary increase in BUN and creatinine due to dehydration. Which of the following laboratory finding is not likely to be seen in people with DKA? And you have all these questions in your handout, so you don't have to write nothing. What would not likely to be seen? If you have DKA, I should not see a CO2 of 45. A CO2 of 45 is normal. And so if you have DKA, you should be cause more breathing, blowing off your CO2. Your CO2 should be less than 35. And you'll see here, people with DKA should always have a high potassium level.